cancer smells bad. Ask Professor Brooks. Walk in and see, you know, squamous cell eating away at someone's face. It does not smell pleasant. So today's talk for Phys Di is going to be, what do I write down on the chart when it looks like that? Okay. And then you can, as you see the pictures throughout Clin Med lectures, go, okay, that's morbilliform, that's dermatomal, that's exudate, that's eschar. So you'll hear all these words, but we'll give you a base today of what you're looking for. So probably for next year, we're going to move integument to the beginning of the year. It just doesn't, it's intuitive to me that we should talk about it first, not hematology. So I'm already voting for moving, like hematology needs to go at the end, and this kind of stuff needs to go at the beginning. This is the first thing, when you're teaching general appearance, one thing you're looking at is their skin. Are they clean? Do they shave? Is it a bearded woman? Because that woman has what? PCOS, until proven otherwise. So derm touches on everything, and I think the idea of putting derm at the end of the year was it encompasses so many diseases, systems, but really, my humble opinion, it should be at the first of the year. You guys have already looked at hair, felt hair. I love it when you go and you look at the SP and you look at and you say, oh, they've got normal hair pattern, no thinning eyebrows, you know. So you guys have already been looking at that kind of stuff, right? Okay. So what do you need to be thinking about with the history? Everything, okay? The one thing that can trip you up with derm is you say, oh, I can see it, so I don't need to take a really great, thorough history. But, you know, still try to do that, even though you look at molluscum contagiosum and you can see it across the room and you know what it is. Still get that history. Very important to get that chief concern, because most of the patients there are there because why? They're either itching uncontrollably and it's affecting their life, you know, they can't sleep, or this skin condition is embarrassing to them, things like that. So a chief concern is very helpful when it's the skin, because people are concerned about their appearance and the way they look. There used to be an ad, you may have seen it come up through magazines or online. If hepatitis C was worn on your face, everybody would go get checked for hepatitis C, you know, but it's silent, and so people forget to check for that. Well, people will come in with the skin complaints frequently, okay? So you're going to learn in this module, when do I need to be worried about a lesion, okay? So what is nice about derm is that certain conditions tend to pop up, for lack of a better word, in specific areas. So you'll find throughout your Clin Med lectures that you're like, oh yeah, psoriasis is almost always on the flexor aspects, on the posterior joints, you know, joints that flex. Psoriasis. Eczema tends to be on the other side of it. And so you'll see this throughout your Clin Med lectures, that just start packaging away where things tend to crop up, and that'll a lot of times set you on your differential reliably, okay? You do want to know also, did it pop up everywhere all at once? Was there one single lesion that you saw first and then a week later you had it everywhere? Number one thing, what do you always want to ask a person when they come in with a rash? The first thing you want to ask intuitively, what do you want to ask them? Does it itch? And probably they're going to tell you that. Is it itchy? Is it painful? Does eczema itch? Horribly. Does herpes zoster itch? Hurts. So you can use those historical facts to help lead you down the right path on your diagnosis. Have lesions changed or evolved? That is big for moles, okay? People will come in and say, I have this mole and I'm worried about it. So the first thing, intuitively, what do you want to ask? Has it changed? Has it always been that way? Like in the last month, has it started changing? So changing, evolving, borders becoming irregular. Always you want to know those things. Okay? And then, of course, what have you been putting on your skin? Have you started new makeup? Have you started new lotion? Have you changed detergents? And we'll go here in a minute to their social history, but we'll get to that. Review of systems, we've trimmed down. If some of you downloaded the lecture that was on there from last year, we've trimmed down the review systems quite a bit. Many of these you've already asked in other systems, like hair changes, nail changes, things like that. Newer changing lesions, newer changing moles, and there's the does it itch, color of the lesion, color of the skin itself, jaundice, pallor, erythema. So what other things when you're talking to a patient with a dermatology complaint would you think are pertinent to their situation? So just some generalizations, okay, for any skin complaints. One of the first questions out of your mouth should be, have you started any new medications lately? Who in our class has had some drug eruptions this year? So like the first thing, did you just start a different medication that may have made you break out? Sometimes you'll have a medication that doesn't bother you until you add sunlight. Then you have medication plus sunlight, they get a rash. And so sometimes you need to take it one step further and say, have you been out in the sun more recently since you've started this new medication? Okay. Have you been in the hospital recently? Have you traveled recently? I came back with who saw my bites after my trip? Did you just get out? Did you just come back from? Did you lay on the beach and exfoliate yourself with sand fleas? Fever is a huge one. I may have skipped over in the HPI part. Like, do you get a fever with this rash, especially with kids? Okay. And how many systems have we said ask them if they use drugs? All of them, right? So any recent drug use, methamphetamines, cocaine. Any kind of amphetamine can make people itch and scratch. Has anyone seen a cokehead tweaking in the ER yet? Or a crackhead? Yeah. Yeah. Those who have been in the ER may or may have seen that. And they will scratch themselves into excoriations. Okay. Family history is important, and not just has anyone had a rash like this before, but family histories of asthma and allergies are going to go with eczema. Okay, it's like the triad of eczema, of atopic dermatitis. Really, we don't understand everything there is to know about autoimmune disorders, so any family history of autoimmune disorders I would leave in the differential for somebody that has some weird skin thing. Okay. And then, of course, Stacy, we had the scabies at Good Shepherd. The patient classically will come in and like, everybody in the family's itching. We've all been itching. So ask about if somebody's coming in with a rash. Has anybody else in the house had the rash? Has anybody else been scratching or itching? Does anybody else have the flea bites? Things like that. And then you got to treat the whole family, or they'll just come back. We'll do that. So a good occupational history is very important for derm because of what? Environmental things, toxins, dyes, chemicals, things they're coming into contact with. People that work in that wash their hands frequently, if they're a housemaid or a cleaner, and they'll come in with the eczema on their hands. Hunters that touch, raw meat or animals if they're skinning things in the field. Florists come into contact with different plants that that might otherwise not. Hairdressers, what do they touch? Hair dye. So just thinking, especially if they come in with it on their hands. What are they touching? My niece developed this rash that was only on the anterior part of her leg up to her knee. Guess what sport she played? So she had some reaction she was having to her shin guards. And we were just like, we never really figured out what it was. We just, switch your shin guards and, maybe knowing her, they may just need to be washed. But just the heat, think about things, keeping compression on an area or letting heat build up behind it. We'll see some pictures of intertriginous dermatitis here in a minute. Always ask about sun exposure. Always ask about, do you go to the tanning bed? Your generation, thank goodness, that has kind of gone away, I hope, right? I mean, everybody in my generation went to the tanning bed. But it's starting to, well, now they tax it. It's like a sin tax now. So just like alcohol or smoking, there's a tax on tanning beds.
Well, I agree with me.
Yes. I think there is an age minimum, but they also tax it with this additional state tax on it now because it's bad for your health. So, sinful. Go to tanning beds. Living conditions are big. So if they're living in a dorm or they've been at summer camp, who has a fun dorm story that okay?
My roommate my freshman year got scabies, and my roommate my sophomore year got scabies.
You did that.
I didn't get it.
I was part of a resident theater company one summer, and there were a bunch of the performers that lived at what they called the big house, and there was a breakout of scabies in the big house, and they all got it. And of course, we're all in the dressing room together. I was like, "Don't touch me."
So contagious. So contagious. So my husband would probably kill me if I told you this. And he went to OU. And my husband grew up on a rural ranch. I mean, just this being in Norman was like the big city for him. So he, of course, was in the dorm his freshman year. Actually, sophomore year, he played football at East Central his freshman year. But sophomore year of OU, first year at OU, random roommate, he goes home for the weekend. And of course, this is his story that I believe in. He's a pretty honest guy. That my husband goes home for the weekend. His roommate let someone use his bed while he was gone, who he didn't know who this guy was. So comes back, gets back in his bed, sleeps in his bed, and ends up with crabs. So again, my husband's pretty straight-laced. Guy. So I believe him. But it gets even better when he goes home. His dad's a rancher, and he's like, "Dad." And he just dusted some kind of powder they dust the cattle with. Anybody come from a ranching family?
Yeah, we use it all the time on them. Like, you just throw it on them as they go through.
It's got some name.
I can't think of it off the top of my head, but it works really good.
It works really good for all your critters. And it's like it was gone like the next day. It was pure just from that powder they use on the cattle. Yeah, don't tell me about those. You may see one someday. Okay. A lot of this kind of stuff is self-explanatory. Yeah, you might need good light, right? Okay, comfortable. How many times have we told you to make the room comfortable? Okay. One thing you do need to make sure you have is you don't always think intuitively you need a chaperone, but you're going to be disrobing and looking in crevices and areas that are very personal, and having a modest patient, and in the time we live in now, you need a chaperone with you. Okay. Tools that you may or may not need. Woods lamp. Who knows what a woods lamp is? You'll learn more about it as you talk about rashes and things like that, but it basically just shines UV light, certain conditions, glow with a different color. And so you'll learn more about that as you go through. Always measure, so something to measure the lesion with. Our cutoff a lot of times in how we document things is whether it's below a centimeter or greater than a centimeter in size, but do measure things, all dimensions, length, width, depth if it's very tall. Gloves, if you need them. Blades for scraping. And some of you may have seen Professor Hughes just scrape something in the Good Shepherd Clinic and just look at it under the microscope right there. That's kind of what a woods lamp looks like. It's pretty easy to use. So some of the things that glow differently, fungus like tinea on the head will glow yellow with certain fungal infections. Erythrasma, which I've never seen, but it's interesting that it glows a full pink color. I just found that kind of interesting. And then vitiligo it'll just look completely pale white in the lamp. But the lamp will augment or increase those pigmented lesions like freckles or like sun damage will light up. Has everybody seen like
the photos?
The photos where they show like what your skin really looks like if you don't wear sunscreen and those dark spots start popping out. That's a dermatoscope. It's basically a magnifying glass for a derm clinic. Okay. So when you're looking, so the patient comes in with a complaint, like I have this spot on me, what is it? And they're going to want you to tell them what it is that day, right? And you're going to be so uncomfortable starting out because you're not going to have any idea. But guess what? What can you always do? You can always get a biopsy. You don't know what it is. That's the great thing about the skin, okay? Don't know what it is. I have no idea what that is. We'll biopsy it. That's one of the beauties of dermatology. And so you can, most derm clinics and a lot of primary care offices, they'll just do it right then and there on the spot. So, literally on the spot. So you do want to, especially if you're doing a skin check, like just a head to toe, like I'm here for my checkup, make sure I don't have any skin cancers, you do want to develop your own systematic way of looking at everything. And it does mean getting in their armpit, getting between their legs, and spreading their butt cheeks, and just kind of looking all over everywhere. Stretching the skin, touching it, feeling if there's depth, things like that. And again, gloves or no gloves, you're going to have to make that call. Okay? Obviously, if something's oozing, or you're at risk for getting something splashed at you, moist, I would probably glove. If not, I would just wash my hands thoroughly afterwards. If you think it's scabies, please put on gloves. Again, when you're inspecting, making sure you're looking at the places you don't think things can pop up, like the palms of the hand, the soles of the feet, underneath the nail for lesions. Inspecting the skin for hygiene, that's probably something you could tell the minute you come in the room, how the person smells. Pay attention to spreading the toes. I mean, if a patient comes in with a complaint of itchy feet, look in between all those crevices, spread things apart, look under the scrotum, so forth. Palpating the skin's not, obviously is not as important, but you do want to note warmth, coolness, which we've talked about in, cardiovascular coolness to the extremities, Raynaud's, is it hands freezing cold or toes cold. You could quickly check turgor, which we talked about. What does skin turgor tell us? Dehydration is not a perfect way to quantify it, but it's a nice little quick check. And then again, feeling for that, whether the lesions are smooth or raised, whether they have any texture to them. So most of what we're going to talk about are lesions, okay? Any abnormality on the skin we call a lesion, right? So you're going to have to get to the point where you're not saying patient has a skin lesion on their right upper extremity. That doesn't tell me anything. You're going to have to get more comfortable with describing these things. So that's what we're going to go through here. First, two things that you need to be able to identify are, is this a primary lesion or is this something that's happened secondarily as a result of the primary lesion, okay? So your primary lesions are your spots that just pop up. Your secondary things are from scratching, itching, or secondarily getting infected, things like that. So just characteristics you need to think about when you're looking at a lesion, other than where it is, how long has it been there, is it painful, how big is it, has it changed shape recently, is there texture, is it pedunculated? Does everybody know what pedunculated means? It means it's kind of on a stalk, kind of hanging. Whether or not it's, again, elevated off the skin, whether there's texture to it, things like that. And what's the distribution? Is it one lesion or is it in a pattern on the body? Measuring, obviously you need to measure it. You always document in centimeters or millimeters. Okay? And kind of our cutoff is a centimeter. Things that are underneath less than a centimeter in size, we're going to document one way. Things that are greater than a centimeter, we'll document another way. We'll get to that in a minute. I always, when you document a lesion, you're documenting the longest aspect of the lesion first. So if you documented this lesion, you would document it 6 by 4. Okay, so when you're evaluating primary skin lesions, you're going to call it this first, okay? So everybody needs to have a good grasp for what the difference between a macule and a papule is. And it's basically, is it flat or is it raised if it's less than a centimeter, okay? So if it's less than a centimeter and it is confluent with the skin, just flat on the surface like a freckle, that's a macule, okay? Petechiae or macules. If it's a raised lesion, it becomes, now we document it as a papule, okay? Papule is the same size as a macule, it just has depth to it, it's just raised off the skin, okay? So more like a wart or a mole. Many rashes that are viral, that just kind of appear suddenly, especially in children, are maculopapular. They're just a mix of all of it. Some are flat, some are raised. And so if it's just it's a generalized rash and it doesn't really fit into either one of those, it's perfectly fine to call it a maculopapular rash. Okay? So if we get to the size greater than a centimeter, now we're going to document it whether it's a patch or a plaque. Okay, so patches are larger freckles, or like cafe au lait, birthmarks, patches of vitiligo. So if you forget what a patch is, just think those cafe au lait spots, which is connected with what genetic disorder? Neurofibromatosis. Everyone remembers that, right? Neurofibromatosis. Sure. Yeah, you'll have collections of these large spots that are darker than the surrounding spot. Does everyone know what a port wine stain is? You've probably seen a port wine stain, but you may not have known what it is. They're very disfiguring. They can be very disfiguring. They're very dark, like someone has poured wine over a patient's face. Okay, so I'm sure you'll have a clin med lecture on those. So plaques, again, same thing. They're just rough. They have texture to them. They're raised up off the skin. So classically, those are going to be like a psoriasis plaque. So how do I say if this plaque is a wheal, okay? A wheal is edematous, so it's not gonna have that circular form like a plaque would have. It's just gonna have more of a, it's not gonna have any particular shape, but it's gonna be raised and it's gonna be, look swollen under the skin. So like this is classically like hives. Somebody who breaks out in an allergic reaction and gets hives on their body. And these itch terribly. Nodules and tumors. So the difference really between the nodule and the tumor is the size again. So a nodule is going to be between 1 and 2 centimeters. And it's going to, when you feel it, that's why you kind of need to feel these, they're going to feel deeper. They're going to feel like they have, they're, not that, you can't move them on the skin as much, they're going to feel like they're a little bit deeper than those superficial skin eruptions, okay? So who has felt a lipoma on a friend or family member? That's kind of, if you felt a lipoma, that's kind of what these feel like. They're in the skin, they're not fixed, but they feel deeper than just a skin rash, okay? They just have more structure to them. The tumor, same thing, they're just now getting larger, okay? Everybody should know what a blister is, right? So how do we document a blister and sound really smart? Well, we say they're either vesicles or bulla, okay? Again, we go off of a centimeter. If it's less than a centimeter in size, and usually it's going to be multiple vesicles are going to pop up in the same area. That type of vesicular eruption, okay, fluid-filled blisters, usually they're filled with clear fluid. They need to be filled with clear fluid to document them as a vesicle, okay? And if they're larger than a centimeter, they're documented as bulla. If they are fluid-filled, but they're filled with pus or sebum, then we're going to call it a pustule instead of a vesicle, okay? So a classic example is acne, or some people will get like a heat rash that looks more pustular. We would document those as not as papules, as pustules. Okay. Who likes to watch cyst popping videos? Weirdos. So,
Pimple popper.
Dr. My niece is obsessed with these. Like, she's the one who wants to go to medical school. Yay. So, most people have have a grasp for what a sebaceous cyst. The newer term they like to use is epidermal inclusion cysts. It's really probably more accurate than sebaceous cysts because they actually come into the epidermis. They're not contained only in the sebaceous tissue. These actually want to come out. A sebaceous cyst is more like a abscess, okay, like something that formed in the sebaceous tissue and then forms a tract and wants to drain. But an epidermal inclusion cyst is more what we think. When you think of this right there, the guy squeezing the big cyst, that's an epidermal inclusion cyst, is a better way to document that, okay? And those, they can get some force behind them. But if you don't remove the sac from these, what happens? It fills right back up and you get to pimple pop it again. I mean, unless you dig around in there and pull out the entire structure of the cyst, they're just doomed to return. Another term you may have heard off and on through Clin Med this year, I know we talked about it in cirrhosis, is telangiectasia. So you just get these dilated capillaries. That's common in rosacea. You'll see it kind of around the nose. Who knows the band Gin Blossoms? You know what a gin blossom is? It's this. They get that rhinophyma from, it's alcoholism. So they call them gin blossoms. So they get that enlarged nose or skin and telangiectasia on their nose. Okay, So first we say it's one of those, if it is. If it's not, you could call it a lesion. But try to be a little more descriptive on what it is to whoever's reading your note. Then you say if it has any of these, okay? So, whether or not there's scale present. So you can have a plaque that's scaly, or you can just have scaly skin. So, scale of some kind would be a secondary finding. Lichenification, maybe a new term for some of you. It was for me when I was in medical or PA school. It just means that it's roughened. It starts to get some more texture to the skin, and it's from scratching. I'm trying to think of a good, like somebody who, has anybody seen a baby that just has really bad eczema? And they just get so itchy right there in their anterior elbows and behind their knees, and they'll just kind of start to get ridges and thickened skin forming just because, they'll just go, they'll just scratch their little arms. So that's usually a sign that it's been ongoing for a while and it's been a chronic problem if there's lichenification. Two different types of scar. Scar is scar. I mean, everybody scars. It's just how well did your surgeon stitch you back together and meet your epidermal layers so that they were able to heal the best way they could. But then there are some people that just scar worse than others. And it depends on your skin type and things like that. But a bubbled up, tall, big scar, and you can Google keloids and find all kinds of cool pictures, but that's a keloid. Okay? When I was on my dermatology rotation, they would just resect those and stitch it back together better so that it could heal in a more normal fashion. They can try to inject those with corticosteroids. Sometimes that'll help, but those are tough. Some people just make keloids. But then also, this is a bad orthopedic surgery probably right here. Somebody didn't approximate the skin very well, and you can see they probably use staples, like most orthopedic surgeons like to use. So if you don't approximate those epidermal layers, so it's what you'll see, a lot of times you'll want the skin to almost pucker on itself. So you don't want it to involute. If you involute the skin to where it's two layers of epidermis laying on top of each other, it will heal like that. But if you spread it out this way, have the dermis meet one another, it'll heal a lot better. So that's why you'll see those. If the suturing looks really bad the first day, it's all puckered up, it's actually better. You do need to know what excoriation is. This often goes with scabies. If it's from scratching, it'll often be in the line of fingernails, from nails scratching. People will not even know they're doing this because they'll do it at nighttime. And so people that have really bad eczema or they're having allergic reactions to something, trim your nails down. You may not even know you're scratching it. You're scratching it at night. Okay. And then fissuring is another sign that whatever lesion you're dealing with has been there for a long time. Okay. Fissures tend to happen where the skin keeps breaking in a normal place where you spread things apart, like in between your fingers, in between your toes. If you get really bad jock itch, they'll get it in the groin. It's just places where it's staying moist and they're repetitively pulling that skin apart. So, erosions versus ulcers, again, this is kind of just the size of it. Think about it like did it look like this had a vesicle on it, or did it look like it had a bulla on it? So erosions will be smaller. Usually those are where a vesicle has popped and left the skin underneath, like the chicken pox, things like that. And ulcers, of course, are larger, deeper. Oh, the classic honey-colored crusted nose. What does this kid have? This is impetigo. Honey-crusted. If you hear honey-crusted lesion on a board exam, it's a kid, it's impetigo, it's staph. So So that will be on an exam at some point, probably peds, maybe derm. But that's just where they've gotten some scab formation or crusting. Those inflammatory, those white blood cells are coming there to kind of help heal the infection that forms the scab. So we don't typically say scab, we say crust. An eschar, which I didn't put on here, E-S-C-H-A-R, is a big, large crust. Okay, so like if you're trying to get a wound to heal, you'll hear that word eschar, that just means there's a big crust of something on there that's covering it up. And those are good because they're protective. But when you're trying to get wounds to heal, sometimes they can be bad. So atrophy, we talked about vaginal atrophy, right? So, and they talked about it being thin and paper-like, things like that. So that's the skin atrophy, and this is just old people's skin, you know, or somebody that's had too many steroid injections over and over and over and over and over and over, putting too much steroid on, it'll give you skin atrophy. Okay, it just looks really thin and weak. But also, you know, stretch marks, striae are technically, that's just where the skin has been stretched and it's atrophic in those spots. Okay. So we're going to talk a little bit, so we talked about primary skin lesions, what do I call it? And we talked about, then is there any secondary thing going on with it? Now we're going to talk about, now I've seen it, I need a better way to add more adjectives to it, for lack of a better word. We just need more characteristics. And you'll notice these will, sometimes they'll tell you what it is. So, y'all can look at this later, I'm not going to read to you. When we say something is, I'm not going to go over all of these because some of them are intuitive, like I don't need to tell you what linear means, right? But like when we talk about confluent, it's just like a whole bunch of macules and papules have popped up, and then now there's so many popping up, they're just kind of all blending together. So they're confluent. Okay. You do need to know what an annular lesion looks like, because that's going to pop up a lot through ClinMed. Okay. Arcuate is just like an arc, it's like part of an annular lesion, and then circumate is just almost a full annular lesion. Those are just, all three are just forms of the same kind of process. Okay. Reticulated is one that some people get that mottled looking kind of skin when they're cold. Has anyone seen that before? I have a friend whose legs do that. If it has a net, looks like a net flaying across it, it's called reticulated. Can anybody guess what serpiginous means? Snake-like, looks like a serpent on the skin. And then we'll talk about zosteroform here in a minute. So shapes. These are words you can use in your note that the other person reading it is going to automatically like, oh, I know exactly what they're talking about. This is like secret code for clinicians, okay? So if I say something looks annular and you read my note, you're going to have a mental picture in your mind of what I saw, okay? So classically with this, fungus will be your classical, what do we call it in layman's term? Ringworm. I mean, it's going to be your classic ring-shaped annular lesions. Other things can be annular, but your classic one is going to be, if it's itchy especially, is ringworm, some type of a fungus. And that's because those fungus grow outward, and it'll kind of grow out, and then the middle part will quit, and then it'll keep going out. If we call something nummular, it just means round. Why we have to talk in code, I don't know. But nummular, you'll hear nummular eczema. It's just this round discoid lesions that will pop up. These will not have central clearing. Okay, so that's, so when I say something nummular and not annular, you guys can now in your mind think the mental picture. Annular has the central clearing. This one does not. So can you just say it's a plaque? You can. This just gives you a little bit more information. Polycyclic means you have all these different arcuate or circinate lesions that are just popping up everywhere. It's like they're trying to be circular, but they're not. There's our arcuate. Again, it's going to look kind of like a half moon. It's kind of a half of an annular lesion. And this is just the example they gave me on Google, Willis syndrome. I don't know that. That was just the most identifiable one for arcuate. There's a serpiginous lesion. And then targetoid, I usually document as target-like. I really never use the targetoid. There's a classic thing of this is like a tick bite. That Lyme's disease. You guys over here, I think you're getting a rickettsial. Okay, that's infectious disease. Okay, so not only can you give whoever's reading your note more description on the shape, you can give them more description on how the shapes or the rash is arranged, and whether there is a particular pattern to it, which also gives you some information. Okay, so we've documented the primary lesion, we've added any secondary things it might have, we've given them some extra clues on the shape, and then we can give some extra clues on the distribution or the pattern. And so linear, what is linear? Straight lines, scabies. Those little things burrow along and they just bite underneath the skin and they kind of go along in a little line. So linear lesions around the hands and wrists or around the waist, scabies. There's your reticular pattern. Again, some people's skin just does this, like with temperature change, but if you need to document it, that's your word to use. Reticular. I've never seen this. It makes me think of like a particular breed of dog or something, where they've got whorled pattern to their fur. So if you saw this, you would document it as a whorled pattern versus a reticular. Those aren't as applicable as what we're getting to with these. So whether the vesicles or lesions are clumped up together or whether they're just randomly scattered everywhere, okay? That's going to be helpful for building your differential. So typically when you have a bunch of lesions heaped up together in a cluster, that tends to be herpetic-like, whichever herpes virus it is. Herpes virus tends to pop up in groups. So that's why they call that type of distribution herpetiform. You'll also see that with bug bites, though. I can testify to that. I mean, if you've gotten bites from somewhere, they'll just tend to kind of bite you all in one area. So this is a word, as you get to be more comfortable with diagnosing rashes and things like that, you could use the word morbilliform, which just means it looks like a measles rash. But a lot of viral exanthems look like a measles rash. So we've eradicated measles, sort of. I'm going to start on that. So you guys are going to have to be paying attention. It could be measles. Especially if you're in an underserved area, maybe with kids that haven't been vaccinated or international travelers, things like that, it could be measles, and measles rash will typically present in this manner, maculopapular, and just kind of everywhere. And you get so full of rash, you'll just get confluent all over the body. Where it's distributed on certain parts of the body is also important. This is a nice diagram kind of telling you when things pop up, what should I be thinking about? Acne, and that's one everybody has seen. This, again, atopic dermatitis is in the antecubital folds, back of the popliteal, back of the knees. something that popped up because of skin sensitivity with a drug or a photosensitive reaction is gonna pop up on what? The sun-exposed areas of the body, the shocker. Psoriasis rosea, which you guys will learn about in Clean Med, that's gonna be truncal always, okay? Christmas tree pattern, you guys will see those pictures later. And then psoriasis tends to go on the extensor surfaces on joints that flex. Okay? So it'll be on the top of the knees, on the back of the elbow. And then everybody knows where dandruff pops up, right? This lady apparently has some chest hair that's in her dandruff. So you guys will see shingles. I mean, there is no way. Have you, anybody had a family member that broke out in shingles? So yeah, everybody has seen this almost. So it is dermatomal. It is pretty amazing the first time you diagnose your shingles before they ever break out in shingles. Okay? It's easy to diagnose when the rash is there. It's catching those people early. I've got this terrible back pain. This back pain is like nothing I've ever had before. My skin is all tingly right here, you know, so just, this would be the differential diagnosis for back pain, new onset back pain, okay? It follows the dermatome, and it does not cross midline. I mean, it's just, it's classic. It will hurt, not itch. It will blister. And it will be there for a while until it heals. And then people develop post-herpetic neuralgia and they hurt for weeks, even after the rash clears up. This was a new one for me, this Blashpoid. Never seen it. But this is very specific. I mean, if you see this, it's rare, but it follows the lines of embryonic development. So it's weird because it'll be longitudinal on the legs, but it'll be circular around the trunk. So just thought it was interesting. You may not see Blashpoid, but you will probably diagnose lymphangitis at some point, okay? Cat scratch fever, that's the classic. Got a cat scratch or a cat bite on my hand, and now I have red streaks going up to my armpit, okay? This is almost always strep or staph. And again, it'll follow the lymph vessels up the arm. So you'll see the redness, and it will start distal and work its way proximal. And these patients are usually sick, they're feverish, they don't feel good. And so if you see anything like that, you need to be asking, like, did you cut your finger? Have you, did you come in, have you been working in the garden and you got something, dirt under your fingernail, or is any kind of trauma to the hand? We'll give them this. Or did you get in a cat fight, literally, with a cat? Acral versus truncal is just whether it's, acral is on the hands and the feet, truncal is, on the body. This is, to me, kind of a no-brainer, but you have to think of it. If things are popping up on the sun-exposed area, especially in your older people, what do you need to be thinking about? Skin cancers. Why the left side of the face? Right, driver's side window. Lots more skin cancers on the left side of the face. In America, it's probably different in other countries. But then when things pop up and they're only popping up in areas where the skin has covered, that's going to lead you down a completely different path with your differentials. So that's always a good thing to be thinking about. Is this popping up on places where the sun has been constantly on that part of the skin, or is this popping up where things have been covered up? Again, here's just pictures of the extensor surfaces for psoriasis and then the flexor surfaces for atopic dermatitis. And then you can get a stocking and glove distribution. I mean, what other condition do we think about? Hand, foot, and mouth. Syphilis. What about, it's not even skin related, it just hurts there?
Diabetic neuropathy.
Diabetic neuropathy. And then the good old intertriginous areas. Everybody know what an intertriginous area is? Where two skin folds meet. Sometimes it's skin folds that aren't supposed to be there. Sometimes it's under the things that are there, like breasts. But what likes to live in these areas? Oh, the good old yeast. They're like the warm, moist areas. Everybody knows how to treat this now, right? Did y'all talk about this in diabetes? No, not yet?
We tried to go really well.
We'll learn. Diflucan, I mean, you need to give them some oral. Okay. Some other helpful things to classify lesions and skin in general. You do need to know the Fitzpatrick classification of skin types. Does everybody know their skin type? You are on the bottom. You're like a 0. Yes, you were definitely 1. You're probably negative, yeah, you might be a -1. So it classifies you basically on how efficient your epidermal melanin unit is. So you determine their Fitzpatrick skin type by asking them to answer 2 questions. Do you burn after sun exposure? Or do you tan after sun exposure? Okay. Have you ever burned? No. Yeah. And then on the flip side, Bethany, have you ever tanned?
No.
So everyone can classify these 2 ladies, you know. So type 1 is Bethany. Let's try to classify everybody. Okay, let's see. Not everybody, but who in the class would be a 2? Always burn, sometimes tan. Okay, can get a little bit of tan, but it's hard.
Yeah.
Yeah, that's definitely my husband. Who sometimes burns, sometimes tan. Yeah. Can kind of get a tan if you work on it, but yeah. Who is type 4? Sometimes burn, always tan. That's me. Okay. And then never burns, sometimes tan. Anyone? I would say no. And then never burn, always tan. Probably Thatcher's here. So you need to know your Fitzpatrick, how to classify that. You need to know how to identify what kind of mole it is, okay? So you know how I like to put together tables for you, right? You need to know what a halo nevus looks like, an intradermal, a junction, a compound, and everybody can find a hairy one, right? So, who wants to guess what this one is? It's up here. Halo has a halo around it, and if you get that wrong, I'm going to slap you. Okay, what's this one? It's a junctional. And then this one's compound. So junctional, how you tell if it's junctional is it's irregular a bit. It can be kind of flat on the outside and then raised up in the middle, but it looks pretty confluent. You know, it has a good structure to it, okay? But junctional are moles that you should consider removing because it could have some potential for dysplastic change. Okay? And you guys will get more in depth on that later. I just want you to be able to recognize them by looking. A compound one is getting to be a little bit less distinct on the border. So, you know, it starts looking a little bit, I mean, that would bother me. This is starting to look a little bit, the border's too irregular for my taste. I would probably take that mole off. So, different features of the moles, and we're going to get to this in a minute, which is really what I want you to know, but first, you guys can reference this. I mean, things that you want, if you're documenting a mole or a nevi, these are what you need to comment on when you're documenting it. You need to comment on the color, the shape. Shape includes what the border looks like, the surface of it, whether it's flat, whether there's texture, how big it is. And with nevi, you kind of use the 5 millimeter mark, which is about the size of a pencil eraser, just because we know that less than 5 millimeters is usually more of a normal mole. We're not so worried about it. If it starts getting bigger than 5 millimeters, we're worried about dysplastic change. The other thing is, how many does the person have on their body, okay? So typically you'll have 10 to 40 moles scattered over your body. And so some people are molier than others. I don't know, is that a word? But then you have your patients that come in and then they have like more than 100 moles. Do we have anybody that has like more than your moly person? Okay. So she would be one you're wanting to frequently check. And you'll have those patients that don't have anybody else, nobody checks them except you. And so, every year you've got to thoroughly look over their moles and see if anything's changed. The other is where they occur. So, Oakley, do most of yours occur above the waist on sun-exposed body?
Yes.
Okay.
I believe they do.
Yes. So see, but again, you don't check those other areas all the time. But for people that are at risk for more dysplastic change, they're going to be. You're going to worry more if they're on their scalp, if they're on the breast, the buttocks, the places that are covered more often. In our culture, they're covered. Yes?
So, you might have already said this, but when does it, change from a freckle to a mole? What is that?
So, that's a good question. So it's all based on the size, and it's based on how, is it there all the time? Or does it just, my freckles go away, a lot of them in the summer, or in the winter, and they pop back out in the summer. So do they pop back up when the sun comes back out, or is it there all year round, doesn't really change? Okay, and then again, the size and the texture to it. So if it starts to it has more depth or height to it, then it's going to be classified as nevi. And so you'll hear this again probably more than once during derm, is the ABCDEs. Used to be the ABCDs without the E of when to be concerned, because you're going to look at a lot of nevi. You're going to have family, friends, possibly people off the street. They're going to ask you to look at their moles and ask you if you should be worried about it. So you just always pull this out of your back pocket, not literally, figuratively. Look at the symmetry, okay? This one should not bother you. It's nice and round and symmetric, pretty. This one's looking ugly. I mean, it's just getting, I liked when Dr. Lorenz said it's not respecting the boundaries of the duct. This isn't respecting the boundaries of the mole. So if it's asymmetrical, borders are uneven, and it used to look like this, now it looks like this. I mean, that's bad. Also, how heterogeneous it is. Is the color homogeneous throughout the nevi, the nevus, or is it just kind of speckled and discolored? Then, of course, the size. So the bigger they get, the more you start worrying about dysplastic change. We talked about that. And then evolving, meaning, did it look different last year? Is it changing? Is it becoming disrespectful? Hair and nails. I mean, I'm so tired talking about hair after thyroid. Really what you need to look for is thinning, which we talked about ad nauseum. Obviously, if they're losing patches of hair, like alopecia, I'm sure you'll have a lecture on alopecia, and then whether or not they're having male pattern baldness in women even, So you can, if the normal male pattern baldness in a man, that's to be expected, right? But women can also get that too, where they're losing it kind of in the same place as men will lose it, okay? It's almost always hormonal and associated with aging and hormones. Who wants to pick through and look for lice? Who has done head checks for lice? I was a lifeguard, yeah. Who did it as a lifeguard? Who did it at summer camps, or, and where did you do lice?
I had to check myself.
That's the worst. I should have put a picture of me going through my daughter's hair, because she got it at school a couple of years ago. I'm telling you, it doesn't matter how clean they are at home. I go to school and get next to other kids, and those lice, they will find the cleanest dang hair in that classroom. But I'll find that. You guys will enjoy it. It's a pretty funny picture of me picking through Cameron's hair, which is quite addictive. What is normal for nails? Okay, longitudinal ridging is normal. Okay, everybody knows what normal nails should look like, right? What is abnormal for nails? Yellowed fungal infection, they get soft and kind of mushy. You always, always, always connect splinter hemorrhages with endocarditis, and repeat that into your head. And then the pitting is most commonly found in psoriasis. And then, again, nail flooding. You guys, I'm sure are tired of hearing about this. You know, I wish we could figure out how to make this useful to medicine. I'm sure it was useful 200 years ago, but not so much now. Does anybody remember spoon nails from anemia? Or does that feel like that was 25 years ago? Yeah. And then onycholysis is just where the nails start painlessly separating from the nail bed. Bow lines are just a very they're not like those longitudinal ridges that you get on. These are horizontal ridges, and they're very distinctive. It's just like one line, and they'll be on all of the fingers. It is a mark in time that something happened, whether they had hospitalization for a cardiovascular problem, or they have a horrible infection. It's basically just like the nails didn't grow and something happened, and then they start back up and it'll grow out. So if you see patients that have that, you can just reassure them that those bow lines will grow out and go away. All right. Questions?
Oh, that they call it clouds.
Those are normal. I don't know what they're called. I think I used to have that on the slide. But they're normal. Like you don't have vitamin D or something. I don't remember that. They're normal.
If you use the phrase herpetiform and that is implied, like vesicle, do you still have to go through all that other stuff, even though that was in there specifically?
I would still say it was a vesicular eruption and a herpetiform distribution.
Oh, okay.
Something like that.
Yeah.
If you tell somebody it's a herpetiform pattern, and everybody will know it's unilateral, it's red-based, vesicles, things like that.